Hey everybody, welcome in to our special lecture today. And hopefully you guys are all on your lunch break joining in with us. I'm super excited for you guys to be with us today and make sure we're live. Yes, we are. So I'm very excited to introduce our special guest, Dr. Aseem Desai. And he is an electrophysiologist in Southern California. He is a premier electrophysiologist who works with the best tools out there, and he does cutting edge treatment as well as does speaking. So I'm super excited he's here with us. Thank you, Dr. Desai, for being here.
Thank you so much, Jennifer. Hello to everyone out there. As my 4-year-old says, happy Friday to everyone. So I practice in Southern California, and my background is primarily in electrophysiology, anything from AFib to VT, the whole gamut of ablation, device implantation, drug therapy. So I look forward to a good discussion today.
Yeah, well, you know, you're just in time, Dr. Desai, because last week we did something called a 5-day EKG challenge. And one of the things we focus on are some of the high risk EKG findings. And so on day 4, we talk about hypertrophic obstructive cardiomyopathy. And some of the questions that came up, they had some great questions. And one of the biggest questions was, what are we going to see in primary care? A lot of people work in primary. What are we going to see in primary care that's going to make us worry? And then on the other side of that, what kind of arrhythmias might we see? And what is your opinion on the whole thing with HOCM?
Yeah, absolutely. And, you know, there's a lot of interest now in high school screening. As you know, HOCM is probably the #1 cause of sudden death in athletes, including high school athletes and competitive athletes. Long QT syndrome is another big one that's under-recognized. So that EKG, that screening EKG, so whether it's in the office, for example, on a routine physical, or whether it's in a high school setting, is going to show you the left ventricular hypertrophy and the repolarization abnormalities that can accompany HOCM. And usually the LVH, usually the R waves are pretty tall, and the repolarization abnormalities are fairly prominent. You know, the other thing that you could see is left atrial enlargement on the EKG, because you know, the difference between an athlete's heart, where you can have hypertrophy on an echo, for example, you won't see chamber enlargement in the atria. You can sometimes see left ventricular enlargement, but you typically won't see chamber enlargement in the atrium, as opposed to HOCM, where it's a diastolic heart disease, where the atrium is having a really hard time sort of pushing blood into the ventricle because it's stiff and because it's thick. So you can see the P waves be broadened and tall and sometimes even biphasic on an EKG. So, you know, to get to your question about healthcare providers and what you can account and see in the office setting, it would be a patient, for example, just on a physical exam that you hear murmur. Typically, it's a kind of harsh systolic murmur. And classically, you can do different maneuvers to augment it in the setting of hypertrophic cardiomyopathy. So it's all about reducing the cavity size of the left ventricle. So things that reduce preload and afterload can help to shrink that cavity and augment the obstruction from the left ventricle to the aorta, because it's dynamic, and then thus augment the sound of the murmur. So doing a Valsalva, for example, tightened hand grip, squatting versus standing. These are different maneuvers to either augment or reduce the murmur. So that could be one of the first tip-offs. It's just that dynamic aspect to the physical exam. And then the EKG, as I mentioned, and then typically, if any murmur is heard, especially in a young person, they go straight to echo, and that's the gold standard for the diagnosis. Cardiac MRI is being used now more and more for different disease states. It's especially helpful with hypertrophic cardiomyopathy because you can measure left ventricular muscle mass, and that actually is a predictor of not only sudden death, but just general outcomes. You can also see late gadolinium enhancement, which can sometimes indicate a fair amount of scarring, fibrosis, and that actually counts as a risk factor for sudden death. So the two groups of arrhythmias that you typically see with hypertrophic cardiomyopathy, the atrial arrhythmias would be AFib, for example, and then you have the ventricular arrhythmias. So for the sudden death part, the mechanism is typically VFib. So it's not that common to see HOCM patients have monomorphic ventricular tachycardia like you would see, for example, in a patient with ischemic heart disease. You can see it. You can see non-sustained VT on outpatient monitoring, and a high burden of PVCs or non-sustained VT is a risk factor for sudden death. The thickness of the ventricle over 3 centimeters on the septum counts as a risk factor for sudden death. Family history of sudden death, for example, and then exertional symptoms. So exertional syncope is a big red flag for us, especially in a young athlete. If they faint with activity, then that implies that you have that outflow obstruction and you have reduction in blood flow coming out of the heart and then to the brain. Exertional chest discomfort as well, because those arteries are being compressed by that really thick heart muscle. So people can get exertional angina. So if you have a young person or any patient really that has sort of exertional chest discomfort and there's no obvious sign or reason for them to have coronary artery disease, another thing to think about, especially if they have a very hypertrophied muscle, would be hypertrophic cardiomyopathy. And there's really two types, right? There's the asymptomatic or asymmetric septal hypertrophy, where you get that LVOT obstruction, and then you have diffuse hypertrophy. And so the diffuse hypertrophy is seen more so in older patients.
Yeah, good call. So it's funny. I'm glad you said that. We teach if it gets softer this with squatting, definitely worry about that more. So thank you for emphasizing that. And you brought up a lot of good tips, because there is a lot of debate about two things that you brought up. One, why are we not doing EKGs in sports physicals? And number two, there's always been this really difficult time discerning, is the LVH in a young person due to an athletic heart, or is it due to HOCM? And so that's a very beautiful tip that you gave us, that they can see atrial enlargement, right, with the HOCM, where they may not with athletic heart. And so what we teach is we look for the notched P wave, like you said, the biphasic, or we can look for a bigger P wave, as indicated with right atrial enlargement. So those are really good tips, and you have completely blown our minds already. So thank you. And I know I heard a little Bird told me recently that you wrote a book about AFib, and so I am not gonna not miss that chance to pick your brain about AFib, because this group, they love their arrhythmias. And so let's talk a little bit about AFib. And what is your book called? It's called Restart the Heart.
Yeah, it's called Restart Your Heart, the Playbook for Thriving with AFib. And AFib, I have a variety of different analogies for it. Electrical cancer is one that I use. It's a progressive disease. And I think we used to think that AFib, paroxysmal AFib, 1 or 2 episodes a year in a low stroke risk patient, can just monitor it. Well, it turns out now that every episode of AFib changes the heart electrically, structurally, to facilitate more AFib. So we have that term, AFib begets AFib. And so as a result, as electrophysiologists, we've really become specialists in the area of AFib, both in the diagnostic component as well as all the new treatments. One thing we know about AFib as well now is it's a systemic disease. So you have to treat the whole patient. You have to treat mind and body. You have to treat sleep apnea. You have to treat obesity. You have to treat diabetes, alcohol intake, big one. A lot of people used to think it was just holiday heart. Well,
Right.
it turns out one glass of alcohol is associated with an 8% risk of an AFib episode. So we advise people completely stop drinking. And a useful thing to say is, if you want to avoid another ablation, stop drinking. So we use a variety of those techniques. I can't emphasize enough the component of weight. I've had patients that have had multiple ablations, Cleveland Clinic, with us, and it wasn't until they lost weight, they made that commitment or had bariatric surgery or whatever it took, they lost that weight, their rhythm normalized. The same thing with sleep apnea. I have one patient who undergone multiple procedures, and every time he came to the office, he denied symptoms of sleep apnea. Wife came one day, he snores a ton. Did the sleep study, treated sleep apnea, AFib literally resolved. So I can't emphasize enough the aspect of treating triggers and risk factors. And in fact, if you think of AFib as the fire, you think of risk factors as the wood, uncontrolled diabetes, uncontrolled high blood pressure, dry wood ready to be set off on a fire. And then if you think of the triggers, alcohol, stress, dehydration, electrolyte deficiency, stress is a big one, especially right now during the pandemic. So many of our patients are getting AFib issues, combination of stress as well as less physical activity, weight gain, and of course, alcohol sales have gone way up as another trigger for AFib. So AFib is electrical cancer. That's an important point. As many people know, the triad of consequences from AFib includes stroke, which is the biggest one, the most catastrophic, congestive heart failure as a result of that chronic tachycardia and weakening of the heart muscle. So that would be the systolic component, systolic dysfunction. But then the diastolic component, heart failure with a preserved ejection fraction, people who have any kind of diastolic dysfunction, hypertrophic cardiomyopathy, for example, that atrial fib is not well tolerated because those patients are so dependent on diastolic filling, and the atrium account for about a third of the contribution to filling.
Yeah.
So when you lose about a third of that efficiency or that filling, it can really have a big impact on a HOCM patient, for example. And then the last piece of AFib in terms of consequences is the reduced quality of life. And it's really, I think, underappreciated how much these patients suffer. AFib is the great masquerader. People can be in AFib, and I'm sure you've seen this, Jennifer, and many of your listeners, that they didn't realize they were in AFib. And it's not until you get them into a normal rhythm and you restore the rhythm, people notice, oh, wow, okay, this is what I'm supposed to feel like. I have one gentleman, his primary symptom was depression. That was his symptom of AFib. And
Yeah.
it was when we restored his rhythm. And we know the connection between mental health and heart disease, and you're not perfusing your body as well. And so it makes sense. If you're exhausted because of the AFib, you're going to get depressed. So, we always tell people learn to take your pulse. It should be part of your daily
Oh,
ritual.
great. Oh,
Apple Watches are great. The cardiomobile device is great as
yeah.
mechanisms to screen for AFib. So it really is a very common disease. 1 in 4 people over the age of 40 will get AFib. So 1 in 4 people on this call will get AFib over the age of 40 at some point in life. So our ways to reduce our chances is to really identify and modify these triggers and risk factors.
So, in talking about curing AFib, so, I just want to see if you approach AFib the same way. So, when you first diagnose someone with AFib, your whole treatment strategy is based on getting them out of AFib, right? Because AFib begets AFib. And then as you go forward, right, as they become more permanent, then it kind of becomes too late for them to have an ablation. So you kind of want to hit that sweet spot, right, and get them out of it, do the stuff to fix them while modifying risk factors. But for you, and the point I want to make, because I know you do a lot of ablations, when when is a patient not a candidate for an ablation anymore in your mind? I mean, based on atrial size, based on other things.
Yeah, that's a great question. I think, Jennifer, the most important thing is you have to individualize to each patient. So the reason why I wrote the book is a gentleman who had been in AFib continuously for 5 years, who had long-standing persistent AFib, was told by numerous people nothing could be done. He wasn't a candidate for ablation. Well, I asked him the most important question, which was when he was cardioverted 5 years ago and he stayed in sinus rhythm for a week, how did he feel? He felt amazing. He felt great. That's all I needed to know. Then we embarked on a process together, and it's important to set the expectations for people of what to expect, what their success rate's going to look like, the fact that it's not just a one-stop shop, the fact that, again, like the electrical cancer analogy, you have to come up with a treatment plan. For some people, cancer treatment just involves drug, some people surgery, some people radiation, some people a combination. AFib is the same way. Paroxysmal AFib, you treat it early on with trigger modification or in many cases ablation, you have success rates now approaching 90%, whether it's cryoballoon or whether it's radiofrequency. If you look at more progressed AFib, persistent, long-standing, persistent, there are still ways to get those patients into sinus rhythm. It may not be just an ablation. It may be an ablation and then long-term treatment with an antiarrhythmic drug, for example, like dofetilide, something that doesn't cause organ toxicity, such as amiodarone. We always try to choose something that is tolerable long-term. And so we use dofetilide a lot, Ticasen a lot in our patients with longstanding AFib because it actually is relatively effective in combination with other treatments. The
Hmm.
torsades risk is actually
Yeah.
relatively low. And
Okay.
so if you look at all the antiarrhythmic drugs out there, dofetilide is actually the least harmful. Like it's
Hmm.
not going to trigger, for example, the class 1C antiarrhythmics like flecainide, you can't use in people with coronary artery disease or any
Right.
structural heart disease. You can't use in people with heart failure. Well, dofetilide you can. A lot of studies have shown that. So that's one that we often will go to. But the treatment of patients and deciding who's an ablation candidate and who's not, you have to establish whether someone has symptoms, and you often don't know if they have symptoms until you restore their rhythm. So we do have a general philosophy which is unless there's a strong contraindication, it really should be considered at least to do a cardioversion, even if they go into sinus rhythm for a day or for 2 days. and they feel different and it
Mhm.
can be really subtle, it's worth then proceeding to try to adopt a rhythm control strategy. The
Mm.
Affirm trial, which was
Yes.
back in 2002 now, the Affirm trial comparing rate versus rhythm control is basically obsolete. At that time, very few patients got ablated. People were on antiarrhythmic drugs that have a lot of toxicities, and people were allowed to go off their anticoagulation if they showed that they were in normal rhythm and follow up. So we know that a lot of patients have recurrent AFib or silent AFib and can be a stroke risk. And if you take them off anticoagulation, they can be at very high risk. So a lot of people used to quote this Affirm trial,
Yeah.
and it's really obsolete. And if you look at the recent data that was presented actually just recently at AHA, we have data now that shows that if you go to ablation early on in the treatment process, you're actually going to have a much better outcome than if you go the drug route. But it's not all about ablation, as you mentioned, Jennifer. You have to kind of risk stratify. You always want to identify risk of stroke first. That definitely needs to be evaluated first off. You need to decide that day whether that patient needs to go on a direct acting or anticoagulant or warfarin or referred for a Watchman device. Those kinds of decisions should be thought about that first day. And unless there's a strong contraindication not to, you can start someone on a DOAC right away, even with samples in your office, as long as you've assessed renal function in many of those cases. And you look at that stroke risk, and then you look at what is their rate like in the office.
Yes.
Is it really fast? Then you would initiate some kind of rate control, and then you take that moment then to decide and talk with the patient about the pros and cons of these
Mhm.
different treatments. And the other thing to mention is the patient's spouse or partner, significant other, friend. Sometimes they're the ones who notice the AFib more than the patient. So I've had people say they were more pale. They lost their color when they were in AFib, and when we restored the rhythm. So there are very subtle cues as to when someone has symptoms related to AFib.
How do you feel about magnesium oxide for AFib?
Yeah, I mean, magnesium, I'm glad you asked that, Jennifer. Magnesium is such an important electrolyte. If you look at the cardiac action potential, magnesium is a key portion in the middle of that action potential and stabilizing the cardiomyocyte membranes. And so magnesium reduces the frequency of premature beats, PVCs and PACs. We know that serum magnesium levels are not very helpful because most magnesium and potassium is stored in tissue. So if you get a serum magnesium level and you say, okay, it's normal, I'm not going to put the person on magnesium, but they're having active arrhythmias or palpitations, that doesn't really mean a whole lot. You can do an RBC magnesium level, it's a little bit more accurate, but we have a very low threshold to recommend magnesium to pretty much most of our patients, unless they have really, really, really bad renal disease, dialysis patients, for example. And so you mentioned magnesium oxide. So there's different kinds of magnesium. Oxide tends not to be absorbed as well. So we tend to recommend glycinate, citrate, taurate, or malate. Those are the four that tend to be well absorbed. So Natural Calm is a great product widely available. That's
Yeah.
citrate. Doctor's Best Magnesium Glycinate's a great one. Cardiovascular Research Lab Magnesium Taurate is a great one. There's magnesium oil. So for people who get GI upset from oral magnesium, magnesium oil, magnesium bath flakes, magnesium spray, definitely. And there's a lot of foods that are high in magnesium. So I'm glad you asked that. It's really important as part of the treatment. A lot of people have this debate about, is magnesium a cure for everything? I would say whenever people make blanket statements, well, actually, I just made a blanket statement by saying whenever people make a blanket statement,
Yeah.
when people frequently make blanket statements, you have to be a little cautious about that. So I do think that magnesium has a huge role.
I agree. So I was just wondering, I know we got to wrap it up because we're both on lunch break from clinic today, but I was just wondering, obviously your book, I'm super excited to dive into it, but it sounds like your book is for providers, but also for patients. So as providers, what are we going to gain from your book other than some of the amazing pearls you've already dropped today? What can we find as resources in your book?
Yeah, thanks for asking. So the book is really a manual, a handbook, and to make it easier for providers. It's hard to have these conversations in these very quick office visits. But
Yes.
here you can say, hey, here's a resource written by an electrophysiologist in an integrative approach to AFib, not just about a procedure, but about diet changes, nutritional changes. We have charts in the book that people can literally fill out to help lose weight, to change their lifestyle. There's self-assessments, there's lists for questions you can ask your doctor, lots of great illustrations. I contracted with a medical illustrator, and I think that's one of the biggest advantages of the book is it shows people the disease, the procedures, just pretty much everything under the sun with regards to AFib. So I think it'll make your job easier when you're practicing and you're seeing patients, because people are going to be informed. They're going to be informed about the disease. They can then ask the right questions and
Right.
be able to understand all their different options. So I would see that, and even the analogies that I use in the book and the way I explain things to patients can be pearls that can be used by healthcare providers. So you can use the analogy of electrical cancer, or the triggers and the fire and the matches and all those kinds of things that we can, probably not the best thing right now in California with the
Right.
wildfires, but
Right.
generally speaking. So I see those to be advantages for healthcare providers as well as with patients.
So one last thing before we let off, and I know there's a lot of questions in here, so hopefully you'll go back in the chat later and answer questions. But I'm really wondering if you could, so I know we have a lot of primary care PAs and Ps in here. If you could tell any of your referring providers a nugget of something before they refer to you, what would you want them to know before they send someone to you for AFib? What could they do? What could they think about? What could they order to set you up to win as the electrophysiologist?
That's a great question. First of all, I would highly recommend referring to your local electrophysiologist. Like, have a low threshold for that, because it's hard to keep up with everything. All of us know that in medicine. This is all we do for a living, is deal with AFib amongst other arrhythmias. And so if you're able to refer to your EP or through your cardiologist, however it happens, we have patients directly approach us even and self-refer. But I would have a low threshold to refer early on. Assess risk of stroke, get them on the right treatment, order the echo. If you need to get a rhythm monitor, sometimes that's helpful to have. 24-hour Holters are not very useful unless you're just trying to assess rate control in chronic AFib. So I would advise against ordering a 24-hour Holter. I would say get a Zeo patch, get something that's a little bit more longitudinal so you can have a sense of the disease, paroxysmal persistent. So assess stroke risk, get them on some rate control especially if they're having active symptoms, and then get them to an electrophysiologist as soon as possible. Most important thing is really to make sure people know there's a ton of misinformation out there about AFib. People will say they had a friend who had 5 ablations, didn't work, et cetera, et cetera. Just get the information from credible sources, and that would be cardiologists or electrophysiologists.
Awesome. I really appreciate all your time. I know everybody does as well. This was so fun. Hopefully we can do this again sometime, because you are just a wealth of information, and we're so grateful you took time out of your day. So thank you, Dr. Desai, very much. And I hope you have a wonderful day.
Thanks, Jennifer. And just one last point to
Yeah.
make to people is I'm very accessible. You can find me on all social media channels, Instagram, Facebook, etc. It's at Dr. Aseem Desai, DrAseemDesai, Dr. Aseem Desai. Have a website, draseemdesai.com, and has a lot of this information out there. And I definitely welcome feedback, questions. I like to learn from all of you as well. So look forward to continued conversations. And thanks again for having me on the show, and
Sure.
stay safe.